And welcome. Can y'all hear me in the back, which is where most everyone is seated? How y'all doing out there? And we are glad to have those of you who are tuning in from remote. Thanks for being with us, and thanks for staying up until 4 p.m. Central Time for this program on employment and vocational rehabilitation strategies for people with long COVID syndrome. Have I got the right slide up there, Amy? Yes. Yep, come on up if you want. Oh, that work? We're just going to master the technology here in just a moment. Keep it down arrow. Things usually end up the way they start out. I think we're in trouble. What do you think? Yes. There it is. There's one. Yep, the second one. Yeah. Okay, that's all right. Well, I think I got to the title slide. Wow. Okay, this is awkward, but here we go. Glad to be with you all, and a great opportunity to be at the Quality Employment Symposium here in Madison. Last year, we had a tornado, right? But it was 80 degrees in May, and it's not that here today, but it's still great, as always, to be here in Madison. I'm Phil Rumrill. I'm a professor of counselor education and director of research in the Human Development Institute at the University of Kentucky. With me here on the panel are Dr. Malachy Bishop, who's the Norman and Barbara Bervin Professor of Rehabilitation Psychology here at University of Wisconsin-Madison. That's quite a business card he's got. And also Amy Rumrill, who is a project manager with the Wisconsin Center for Education Research, also here at UW-Madison. We are glad to be with you here today. We'll be monitoring the chat for those of you who are tuning in online. We will take fairly regular breaks to see if anybody has any questions or comments. We're glad to entertain them as we go. And with any luck, we'll have some time afterwards as well, because we want to hear from you and what your experiences are in working with the growing numbers of folks who are dealing with the lingering effects of COVID-19. Let's see. Yeah, next slide, please, I guess. This gets a lot better, so just bear with us. Work. Just an acknowledgement and a disclaimer. We're one of the partners. Christina Espinosa, my colleague at University of Kentucky, is here in the Vocational Rehabilitation Technical Assistance Center on Quality Employment and Vocational Rehabilitation, in partnership with many universities and entities around the country. A grant here is housed at the University of Wisconsin-Madison, as many of you know. Some of the strategies that we will talk about today in terms of serving folks with long COVID across phases of the vocational rehabilitation process come from a couple of other projects which don't appear here on the disclaimer. But one that we just finished called Retain Kentucky, a Department of Labor funded project where we serve 3,200 Kentucky residents with mid-career disabilities, which included long COVID, and develop some infrastructure and providing supports to meet the needs of folks dealing with long COVID, often in concert with other disabling conditions. And so we're part of what we have to talk about here today comes from those evidence-informed strategies from that project. We are also in the first year of a Disability Innovation Fund project funded by the Rehabilitation Services Administration in partnership with Mississippi State University, where over the next 4.5 years, we're going to provide competitive integrated employment services, both in job retention for those who are employed when they come into our project, and for those who placement services for those who are not employed when they come in, all of whom have long COVID, all of whom are residents of the great state of Mississippi. And we're going to serve about 750 Mississippi residents over the course of that project as well. So what we're here to talk about are things that we've already vetted in some ways in our Retain Kentucky project, and we're going to test them specifically with a fairly large long COVID sample in our upcoming project. So one project begets, the next, as you all know, and that's sort of where we are right in the middle of this nexus. All right. You. Just a list here of our objectives. We want to um, uh, present long COVID syndrome as an emerging disability among vocational rehabilitation customers and consumers, and we'll talk about that in particular. We want to discuss the impact that long COVID is known to have, although it's new. We are learning more and more all the time about the impact that long COVID has on health and functioning and community participation, and particularly on employment. And then, as I had mentioned before, kind of the overall impetus for this, for our remarks here today, looking at strategies for serving folks with long COVID across phases of the vocational rehabilitation process. And when we talk about the phases of the VR process, it also strikes us that the phases of VR, we're probably modeling most of this on the state VR system, but we believe the phases of rehabilitation counseling usually work the same regardless of the sector, right? You're going to have to do outreach and eligibility before you start serving folks. You got to do an assessment and planning phase, and you look at what folks' needs are, developing the services, looking at health and mental health considerations, and you go out into the vocational aspects of that, the job development and placement, things of that nature, all the way out to retention, post-employment follow-up, case closure. We do this regardless of sector, but the state VR, process always gives us a good framework to talk about it. And so, with your indulgence, that's what we're going to do. But this really would apply to your engagement with folks with long COVID, really in any in any sector of our field. Okay. Thank you. Next one. Yeah. So, semi-rhetorical question, I guess, to get us started. But this does come up from time to time. Why in the world are we still talking about COVID-19? Aren't we in the middle of pretending that this pandemic never happened in the first place? Or don't we wish it did? And can't we put this to rest or to bed once and for all, and we can just stop worrying about it? I mean, why is it still on the screen? What's not on the screen are a couple of things. We know that cases of COVID do continue. The cases tend not to be as severe as they were during the first waves. When people do acquire COVID-19, about the antiviral medications, and I'm thinking about Paxlovid and others that once you get the condition, alleviating the symptoms right away. We've really changed the disease experience of COVID-19 for many people. Think about March of 2020. If you got COVID during that first wave and you didn't know if you're going to be in the hospital or if you're going to make it, and how many of us lost friends and loved ones. And it's not that way anymore, but we're still in the, middle stages, I think, of determining what the overall impact of this public health and economic global, disaster, is going to continue to, impose upon our our national and global societies. So we're still, in the middle of this, and a few things we know about how the pandemic has and continues to affect members of the disability community. We know that people with pre-existing disabilities were more likely to acquire COVID in the first place during the first waves, right? We know if you have a pre-existing condition, really of any kind, you're more likely to have a more negative outcome of COVID-19 than if you don't have a pre-existing condition. So we have seen the undue impact of the pandemic on the disability community. We will submit to you today that COVID-19 has created an entire segment of the disability community, and that's for people who have the lingering effects of long COVID. And we'll certainly, get to that in just a moment. But we know that people with disabilities were more likely to have their employment interrupted during the first few waves of COVID than people who don't have disabilities. And at a presentation where there's 275 QE Symposium attendees here in this room, I don't need to remind you what the impact is on losing employment for people in terms of the health consequences, the impact on self-esteem, identity formation, all of those things, how interruptive it is to lose one's job. So we've got a group of people who are disproportionately affected in that way. This pandemic is going to unduly affect them in all sorts of other ways. We make the point here at QE and in most of what we do that employment is a public health imperative. We know that societies that are the healthiest are those that find ways to engage anyone who wants to work in the workforce, doing jobs that they like to do. And the conduit, we'll get to this next slide, but the conduit to all of the reinforcers that accrue from paid employment, well established. We don't need to belabor that here, certainly with this audience. But we also want to underscore the point that, in general, we know that health is both a predictor and a consequence or an outcome of employment. So we see this ongoing reciprocal or curvilinear kind of relationship, really more reciprocal, between health and employment. If you're healthy, right, it's easier to acquire employment. It's easier to maintain employment. If you maintain employment, your prospects for long-term health maintenance and management go way up. People who work are healthier, happier, live longer, have greater access to resources, greater access to social capital, you name it, right? Quality of life than people who don't. We know all of this. We also know that that the vast majority of people with disabilities who are not engaged in employment tell us that they would like to be, they feel they would like to work, and they feel that they have the ability to work. So to the extent that the pandemic has affected people's prospects for participating in the economy, it also has ongoing impact on people's health, irrespective of whether the symptoms of COVID continue to linger after people are no longer, acute for the condition. So I would humbly suggest this is why we're still talking about COVID-19. And in terms of the work we do in picking up the pieces from this pandemic, we got to look at folks who are dealing with the long-term health consequences of COVID, and that's the folks who have what we call long COVID syndrome. Next, please. I want to pause here and catch my breath as we go to the next one. Questions, comments, thoughts so far about any of these platitudes to this point? Anything? Anything in the chat? We don't mind silence as counselors, right? We'll work with that a little bit. Maybe we should wait till Dr. Rosenthal has a question. Or, no, we will not. We won't. Oh, go ahead, please.
Maybe this
Blurt
is
it out.
something you'll address during the presentation, but in your experiences, are you seeing long COVID more in a specific age group?
We are indeed, and we will get to that, but it's kind of a middle age and older phenomenon. It's just like the original symptoms of COVID happened fairly infrequently to younger people, and when it did, they tended to be more resilient. So older people, when they get it, have a more severe and lingering effect of long COVID. From a vocational standpoint, and Amy and Dr. Bishop will get to this as well, we're finding that most people diagnosed with long COVID are over the age of 50, and they quite often have other co-occurring health consequences. So this is a kind of mid-career and older sort of condition, and that does portend a few very interesting things for how, let's look at state vocational rehabilitation services. That's not the bread and butter of state VR, is it? For people with a lot of employment experience in mid-career. They certainly, are certainly people who have employment histories are eligible for VR, but in the main, VR is preparing people for their careers and arguably does the best job of doing that if you look at outcomes. So yes, there's certainly an age connection and other characteristics as well, which we'll get to in just a moment. So thank you. Thank you. Yes, please.
Rosenthal here. Yeah, any thoughts on physician buy-in and the variability of that? It just seems like some physicians, and I'm making this up, but 3 out of 10 or something read upon on this and will diagnose it, but then a majority of physicians just seem to, it's like the old fibromyalgia or whatever in terms of its not being picked up on.
100%. No, it's 3 out of 11 actually, David. But no, it's I don't know what the numbers are either. But keep in mind, long COVID is diagnosed only by self-report. I'm looking at Dr. Bishop over here. That's how they used to diagnose MS, right? Until the advent of magnetic resonance imaging, you had to rule out all other factors, look at people's clinical profile on self-report. There's not a test for long COVID. It's a constellation of symptoms and. Yeah, just like physicians who don't work with workers' comp clients or these soft tissue and other, where there's no organic or objective basis for it, no screen, no blood test. It gets really fuzzy, and we see that a fair amount of skepticism, not only in the parts of physicians, and so that brings with it a lot of stigma, right? If your doctor doesn't even believe and there are physicians just say, I'm not diagnosed, I don't understand it well enough to say that you have it, even though you seem to be exhibiting signs of COVID-19 long after you're no longer, testing positive. So that's certainly an issue. And we find this often to be the case with what we call emerging disabilities. And we'll get to that in the next, slide or two. Disabilities are conditions that are not well understood, let's just say, are particularly vulnerable to that sort of stigmatization, skepticism, invalidation. But then the person who has the condition often internalizes that, right? It's not, you get that message, all of a sudden you get the hang of it, and maybe you don't think of it quite in that way. And when you don't pursue the diagnosis or don't get the diagnosis, how do you get the treatment and the care that you might need if you can't even get anyone to call it out? If you're not fortunate enough to be near a fairly large healthcare complex, for example, where there's a long COVID center or whatever it might be, and then at different times throughout, and I think we're in a wave of this right now. I think the government, frankly, is in the process of determining whether it wants to recognize long COVID at all. Try visiting the CDC website right now and see what it's saying about COVID-19 in general or long COVID. Well, actually, the CDC website is not up, right, or not much of it. So you'll see these things sort of all of a sudden, just these sort of black holes happening about conditions that come sort of in and out of favor. And the ones that are most vulnerable to that are the ones that are least understood. And if it's a new condition, of course, it's not going to be understood quite as well, right? Appreciate that point. Thank you. Very important. Anything else? Go for it.
I'm Kana Iwanaga.
Of course you are. Yeah.
So is there a specific definition of long COVID compared to COVID?
There is, and I don't want to, Dr. Bishop never
Okay,
wants me to preempt his remarks because he wants to take most of the airtime here, as you all know. And he's going to share that with you. So hold on that for just a moment. Yeah, thanks. Yeah. Are we, Amy, I don't even know where we are. Are we on meaning where you guys, never mind. All of this sort of stuff. And we're just talking about the impact that a condition like long COVID can have on employment. We know how important employment is. It's a QE symposium after all, but we do have a big overarching problem here related to that, and that has to do with labor force participation. The employment to population ratio right now for working age adults with disabilities is around 38%, depending on the study you look at, compared to 73% in the general population, which includes people with and without disabilities. This isn't good enough, at a time of a national labor shortage and a near full employment economy. It's a national disgrace that people with disabilities would be half as likely to be engaged in the workforce as people without disabilities. It's always been this way. We can't seem to move the needle on this. This has been happening since World War II. And it doesn't really seem to matter what the economic conditions are like and things like that. We will get to that. But that very fact that we have a full employment economy and a national labor shortage, it's embarrassing we don't have better outcomes. But there are tremendous opportunities before us and our consumers who do have long COVID as we think this through. There's less and less of a reason for that bottom line figure there on the employment to population ratio to be that way when employers need as much help as they actually do. And Amy's going to share with you some very specific and stark evidence, I think, that suggests we got a lot to work with if we can find the folks who have long COVID, get them into our process, be able to apply the things we already know about job development and placement and job retention. What we're going to suggest here, you're going to look at and say, that's not specific to long COVID. Of course it isn't, because good job development and placement is good job development and placement, if you forgive the redundancy. Good job retention and follow-up is the same regardless of condition. You take every client's individual needs and address them, right? That's what we do. It really is that simple. It's a big part of this is getting folks to recognize, this condition and see themselves as members of the disability community in the first place, so they'll come to us to begin with, but also as viable members of the workforce and viable participants in the economy. And then we've got a lot to work with. We know how to do this. Employers are leaning in the right direction too, because they need the help. So the circumstances are good, but there's just tremendous challenges because these facts here are really stubborn things. Thank you. Please. Great. Yes, please. Yeah. So, we have a rhetorical question a little later about whether long COVID is an emerging disability, but we've been talking about long COVID, but in many ways, we're really talking about emerging disabilities overall. And what are emerging disabilities? Well, by one definition that Dr. Lynn Cook, my friend for years, who recently retired from the University of Arkansas, she and I have been using this definition of emerging disabilities. These are conditions that are either new to medical science, that's a check, right, on long COVID, relatively new, or increasing in incidence or prevalence within one or more segment of a given population. Certainly long COVID also applies there. It's new, and it is in fact increasing, and people tend to survive long COVID over a period of time. So it's chronic and it's unpredictable. We know a few things about these emerging disabilities in general. We know they're often misunderstood to a couple of the questions that we've already had by healthcare providers, by rehabilitationists of all types, by people who have those conditions themselves, by their family members. We know that people with emerging disabilities, as opposed to disabilities that we would call traditional disabilities that don't meet that first two-part definition, they're more likely to live in poverty. They're more likely to be women. They are more likely to be members of minoritized racial and ethnic groups. They're more likely to be to be younger. They're more likely to be older, therefore less likely to be in the middle age ranges. This is emerging disabilities. In general, the symptoms of emerging disabilities tend to be not readily apparent to others. They tend to involve multiple functional domains as well. And so with those disadvantages that people bring into the process, and the fact that if you're dealing with other complexities, in your life, you're more likely to have these conditions. It's no wonder that when you add in an emerging disability on top of that, you're likely to experience invalidation by healthcare professionals, by family members, skepticism about the very legitimacy of your needs, stigmatization and self-stigmatization, experiencing discrimination and just a general sense of misunderstanding, confusion about the nature of the condition. They tend to be unpredictable and chronic as well. And again, these are emerging disabilities in general, but it fits pretty well, I think, on the long COVID definition. We know that people with emerging disabilities are denied legal protections. They're denied healthcare and rehabilitation um, uh, services, subjected to higher rates of discrimination, denied disability benefits at higher rates than people who have traditional disabilities as well. We'll go to the next slide, please. Just some other examples of emerging disabilities. I'm not going to belabor this. Thank you. We will make these slides available to everyone, but some of these really come without saying, and Dr. Chuck can see a few of these here, right? Traumatic brain injury. We know that 2.5 million Americans sustain at least one TBI each year. 500,000 of these people never receive any treatment for their condition. About 7 million Americans are currently living with the effect of TBI. I'm looking at Dr. Bishop over here. We know that 1 million Americans are currently living with multiple sclerosis. That prevalence figure has doubled in the last 12 years. How about autism? I was born in 1968. Wow, I'm getting old. That year, 1 out of 6,800 children born would be diagnosed with autism during childhood. What's that number now when you see the public service announcements? 1 out of 36 births, 1 out of 25 males. So we've really seen a great profusion of autism diagnoses as well. How about 39 million Americans living with diabetes? That's gone up from that's doubled actually since about 1997. We've got a tremendous epidemic of diabetes and other chronic illnesses, stress and trauma related disorders. The drugs of choice vary a lot, so we have to take a look at those and how certain kinds of addictions change in their incidence and prevalence sort of across the population. Age-related conditions, we know there's 73 million living Americans who were born between 1946 and 1964. The baby boom generation, 73 million people, one thing in common. They ain't getting any younger, not one of them, right? And people living longer and longer. So we've got more people advancing into older age. The number of 90-year-olds in America is going to quadruple between 1980 and 2030. The number of people over the age of 65 has reached record proportions in our society. The number of retirees, and inversely then, if you look at that, the number of workers who are there to support the economy, changing demographics. So the changing age demographic also has impact on the disability community and creates this entire new class of people with emerging disabilities by this definition. Next one, please. This is just a screenshot of the book that Dr. Cook and I wrote, published in 2017. Working on the second edition of this right now. And this book has kind of a unique feature to it. It does not include the word or acronym COVID anywhere in it, okay? So as we think about emerging disabilities by that definition, just imagine in revising and updating this book, what we're going to have to do, not just a chapter on COVID, this has really changed the landscape and what we think of when we think about emerging disabilities. So in the next iteration of this book, we've got to go back to look and see whether those conditions that were emerging in 2016 and 15 when we wrote the book are still that way today. Some will be and some won't, but we've really got to update it with a lot of this content from long COVID. And we will go to the next slide, and I'm going to turn it over to Dr. Bishop to talk a little more specifically about why you're all here in the first place, not to hear me go on and on about emerging disabilities, but long COVID. So without further ado, thank you. Thank you. Thank you, Alec Bishop.
I've been working with Phil for about 15 years now, and I love presenting with him because he likes talking as much as I do. And I know if I let him go first, he'll cover everything I was supposed to talk about, which is what he did again. So that's why that works that way. Uh, and so, yeah, we know the answer to that question, right? Is long COVID an emerging disability? Yes, it is. It's affecting about, well, as many as 23 million Americans. It may, I was looking at some more recent data in terms of out of the workforce because of long COVID, 2 to 4 million is what I saw. So yeah, it is affecting people in terms of their ability to participate in the workforce for sure. As many as 50% of Americans who had COVID-19 experience lingering symptoms 90 days after they no longer test positive. And Phil talked a little bit about the relationship between severity of the COVID-19, also the if you have it more than once, if you use the antiviral. So there are a lot of factors involved, and then age and so on, in terms of increasing the risk for developing long COVID. But even those with mild acute COVID symptoms can develop long COVID. I love, do you know the term long COVID originated from the people who had the symptoms? I love that about this term is very unusual in that it actually came from the people talking online about their condition and their symptoms. So pretty cool. It's really hard to pin down the symptoms. There are some common symptom clusters. There are outliers, and then all of this is very new, and we're trying to figure this out as we go. So these are the common symptoms, but there are certainly many others. You do see lung and heart disease, difficulties with breathing, coughing, asthma, and allergies. You see, yeah, there it is, fatigue. But obviously, those difficulties with breathing can affect sleep, and so a lot of these interact with each other. But fatigue is certainly developing as a problem. Cognitive impairment, you're familiar with the am I thought I was shouting, sorry. Sounds very loud to me. I'll talk louder. All right. Brain fog, cognitive impairment, executive function and memory issues. Um, if you have a pre-existing health condition, experiencing long COVID is likely to exacerbate those symptoms, those conditions. Depression is quite high, high rates of depression and anxiety. And yeah, psychological distress and high rates of substance use or relapse. Sort of getting to your question, Kana, a little bit. There is no screening test. Your question is hard to answer because it sort of depends on the context. Like, but like I said, all this is developing and we're trying to figure it out. It does commonly occur with other disabilities. It definitely increases the risk if you have an existing disability or chronic illness. Treatment primarily focuses on the symptoms. There's not a treatment for long COVID, right? Because it's not really a unified. We're not even sure yet if it's like a unified condition or if it's so. There's not a long COVID treatment. The treatment is symptom specific. Certainly, long COVID can subside over time, and basically some of those factors I was talking about, preconditions, can indicate a likelihood of a more long-term condition. Certainly, people are experiencing it for years at this point, but a lot of people seem to recover within 6 months. So it's highly variable. Amy has a lot of interesting things to say about voc rehab, so I'm moving along quick here. Is long COVID a disability by law? And this is a really important question. And the answer is yes, in that the EEOC and the Department of Justice have said that long COVID is a presumptive disability for protection under the ADA, under Section 504, and under Section 1557 of the Affordable Care Act. So yes, the government has said that if you, if you meet the definition of a disability under the ADA, for example, then yes, long COVID is a disability under the ADA. RSA, Rehab Services Administration, does allow for VR agencies to consider long COVID for eligibility determinations. If you heard Dr. Tanzi's talk this morning, he was talking about how we need a lot more variables in the RSA, but long COVID is not one. So it doesn't exist as a category in the RSA 911 database, but it is acceptable in terms of eligibility determination. Yes, Chuck. Sorry.
That can be the main reason you come in.
Yeah, no, let me just summarize. So the question was, how is that coded in terms of RSA and voc rehab counselors? And the answer is basically in terms of the presenting symptoms, typically respiratory. Yes. Explaining to whom? To, oh, yeah, I understand that that is how that is happening at this point. All right, Amy.
Good afternoon. My name is Amy Rumrill. I have been working with Dr. Rumrill for the last 25 years and recently started working with Dr. Bishop on the Career Horizons project in Mississippi State. I'm going to talk about the national labor shortage that's happened as a result of the pandemic, specifically that 50 million people had their employment interrupted since March of 2020. And as many as 10 million of them did not resume employment or have not returned to work. That's 20% of all the people who got interrupted or not back to work, which is a staggering number and is unprecedented in any of our history as far as people exiting the workforce and being able to re-enter the workforce. As a result of the pandemic, there have been 20 million new jobs that have been created since the beginning of the pandemic, specifically related to the changing nature of work and how work is done. We can speak to things like remote work. We can speak to demand in sectors like hospitality and technology that have occurred because of the change that happened from the pandemic. Currently, we're at a record low employment rate of 4.1%. This is the number of people that are available for work and are receiving unemployment benefits. That's where that percentage comes from. We have a lower rate of labor force participation now than we did before the pandemic in February of 2020. And we have a full employment economy. And the definition of a full employment economy is that employers are in need of good workers. They're looking for workers. They have fewer workers to support the economy. And this gives us an opportunity for people with disabilities and people specifically with long COVID to stay in the workforce if we can provide them the supports and resources that they need in order to do so. There are 2 job openings for every job applicant. I've always, as a prior job placement person, I was always interested in how many jobs were available for my particular consumer, and to be able to have 2 jobs for every job seeker is a staggering number to me in helping people with disabilities get to work. We had, as Phil mentioned, we had a project in the state of Kentucky called Retain Kentucky. And we were able to see and talk to employers in the state of Kentucky and ask them about their hiring needs and their staffing needs. And the employers, we were willing to, talk with them about how we could give them qualified applicants, but we really didn't have to talk very long because the employers said to us, bring us the people. We need employees. If they just come apply, we can review their information, and it's very likely that we can provide some options for them, job options. So why is this important for people with long COVID? Because there is this national labor shortage, it gives us the opportunities as vocational rehabilitation professionals. The opportunities are out there. We just need to connect these folks with those opportunities. So next, I'm going to start talking about the strategies and best practices for VR consumers with long COVID. Specifically, we are using these VR phases in our current project with Mississippi State called Career Horizons for the consumers with diagnosed with long COVID. Our first VR phase is outreach and eligibility. In this phase, we're looking at, this slide is blank. Doesn't have the bullets. I do. Bullets. Sorry about that. Now, what do I need to do with the bullets? Oh, there it is. What do I have to? So I want to put them all up. Okay. Okay, phase 1 of the first VR phase is outreach and eligibility. This is how we get the clients, basically. So we want to target a broad range of professionals, individuals, and organizations. Because, as we've talked about already in this presentation, because COVID-19 or long COVID is a new condition, we are in the position to educate employers and consumers about long COVID, about accommodations, and different aspects of the condition that can make it more likely that we can get employers on board and we can get consumers so we can help them get employed. We want to use inclusive language for outreach and education. This is speaking in an understandable way to anyone in order for them to know what we do. So instead of saying to someone, do you want to be a VR consumer? We say, do you want help finding a job, given that you have a long COVID condition? We want to recognize the potential for and address stigma and biases in the eligibility phase. This would be on the part of the counselor. Does the counselor have a stigma or bias related to this condition? And is the consumer self-stigmatizing because they can't work, because they don't understand what's going to happen to them in the future with the symptoms that they're having? And because it's a new condition, we don't really have much data that we can refer to about the long-term effects of long COVID. We also want to screen for depression and anxiety, asking in the intake interview brief questions about any mental health symptoms and conditions that the person has. One of the common symptoms that was on the screen that Maliki just discussed was depression and anxiety. It can be very depressing and anxiety provoking for a person to be experiencing these symptoms that they've never had before. They might have trouble breathing, they have trouble staying at work, they have trouble walking around for a long time. So it can be a lot for a person to have to deal with as far as mental health. People with long COVID are often new to the disability community, and they may not identify themselves as such. They might, if you ask a person with long COVID, do you have a disability? They might say, no, I don't. I have long COVID. So acquainting them with being in the disability community can be something that would be up to the counselor to work on with them. People with long COVID may qualify based on other co-occurring disabilities. So they might have a mental health condition, they might have other conditions that would make them eligible for services. Okay, and I will move on to the next phase in VR planning is the next VR phase is assessment and planning. To stay abreast of new developments in long COVID treatment is an important consideration in this phase. As the consumer symptoms and situation changes, it's very important that the consumer and the counselor are discussing what's going on with them so that they're both learning together. It might inform the consumer's VR plan and the services that they get while they're in with VR. We also want to consider the effects of co-occurring disabilities. As we said, they could have mental health conditions or other conditions that impact them. We want to consider our consumers in the context of being a whole person. So anything that's going on with them, physically or mental health, we want to know about and keep in mind to help them best. We want to make sure that counselors know relevant legislation, especially around reasonable accommodations, assistive technology, and leave policies. If we are helping a consumer get or keep a job, we want to know, especially about accommodations can be very, very important. If we have a person with long COVID, they want to keep their job. We want to know, be able to walk them through the process of requesting accommodation, disclosing their disability, contacting their employer, and what to say about that. Accommodations that a consumer might need for working is breaks in order if they have shortness of breath, and other accommodations that we can inform them about. It's important for a VR counselor and for a consumer to collaborate with both their employer and their healthcare professional. In our Retain Kentucky project, we focused on that collaboration piece with the consumer, the healthcare provider, and the employer in order to have open communication and to let everybody know what is going on. And that was really important in helping our clients to get employed, stay employed. For folks who are already employed when they have long COVID, we have been employed, if they've been employed before they got long COVID, we can do something called a transferable skills analysis to identify different jobs that they could do. So if a person was doing a job that they can no longer do, we look at their transferable skills and identifying job options for future employment. There's a program called SkillTran Oasis that we have used and retained for doing a transferable skills analysis. We also want to keep in mind the return to work hierarchy when we're looking at either keeping a person at their job or placing them at a different job with their same employer, or as their same job with a different employer, or in the final tier of the hierarchy, a different job with a different employer. Sorry, I think I need one more thing. Okay. We also, it is important to make referrals to resources for consumer-specific needs for social determinants of health. When a consumer does not have childcare, transportation, food security, they can't get their prescription medicines, we as VR professionals need to help link them with the resources in order to get those needs met, in order to have a better chance of success in helping them stay at or return to work. We also need to understand the developmental stages of consumers and how that impacts assessment and planning. As Phil mentioned early in the presentation, most people with long COVID are over the age of 50, so they might be in their mid to late career. A mid to late career assistance from VR can be different than it would be for young people. So we would want to ask them questions like, how many years do you want to continue working? Maybe they do the transferable skills analysis and things like that to help mid-career folks. Next VR phase is job development and placement. Sorry, no, Phil, that's not right. Next VR phase is counseling and guidance. In this phase, we are going to understand the potential reservations and barriers of consumers in seeking support for mental health and provide those supports. Our consumer might not necessarily want to get a therapist or counselor to address their mental health conditions. We need to respect their wishes to do that, but we kind of need to keep track of what they're going through and keep providing resources to them to see if we can help in those areas. We need to encourage our consumers to harness their existing social supports and refer to new ones if needed. Consumers, in my experience working with them, they don't always think of their neighbor, their friend, their family member, their coworker as their social support. So sometimes that takes some prompting to say, hey, could you ask your coworker to give you a ride home? Could you talk to your sister about issues that you're having, symptoms you're having with long COVID? So kind of reminding them of the supports they already have and helping to make referrals to different agencies in order to provide supports if they don't have those. Counselors should also educate themselves on the implication of disclosure of long COVID in the workplace and the reservations and reasons for disclosure particular to your consumer. Because this is an invisible condition, because this is a condition that Phil mentioned earlier, the government is not acknowledging in some places, we need to have those discussions with our consumers so that they know their rights in requesting accommodations, practicing with them to request those accommodations. Knowing legal rights of employees with long COVID to provide guidance in the event of workplace discrimination. This speaks to the Americans with Disabilities Act and the Americans with Disability Act Amendments Act. Sort out who to talk to and how to deal with unfair treatment in the workplace, and also negotiating accommodations. The long-term impact of the disease on individuals is not known, so we should be prepared as VR counselors to process that uncertainty with the consumer. They might be overwhelmed, scared of all the symptoms they're experiencing, how they're being treated at work, not being able to do their job anymore. So we as counselors need to ask questions and process that with them as we're assisting them. Bill?
Just a few more minutes left. Looking at the often lengthy phase of job development and placement in the VR process, again, regardless of sector. here of just a few sort of highlights, and they may not be exactly what's here on the screen, but some things to think about. One is it's really important to understand what the local labor market is, and this goes without saying. A lot of the things we've been talking about here are quality VR services. This would apply to any customer or consumer, but the needs that people with long COVID have may be unique to the fact of the condition, that it's new, that it may not be well understood. And I hope you're hearing those things as recurring themes. But understanding the local labor market or even the statewide labor market, what are those hot jobs? Who's hiring in what areas? So active citizenship in your community, never been more important. We think engaging with chambers of commerce, Rotary clubs, employer organizations, trade unions, professional associations. On the demand side, finding out where the jobs are, who's hiring in what kinds of fields, and then making those matches to what people need. So we use the Department of Labor's ONET system for labor market analysis, the ONET interest profiler as a way of getting very quickly a sense of what people's interests might be, because so many employers are hiring, almost everybody's hiring all the time. We know that there's going to be a lot of options, and so why not make that match between the person's interests and skills and the available job as strong as we possibly may. We have this opportunity to do this really in the right way to make these matches because of the sheer volume of opportunities that await our customers and consumers and clients. Understanding the nature of how work is performed and how that's changed during COVID-19. We have up here something, the gig economy and self-employment. How many people do you know who are stringing together 2, 3, 4 jobs, and the new terms we've learned like side hustles and ways that people, and sometimes this is out of sheer necessity, but sometimes it's spawned these entrepreneurial opportunities for people. Because of the sheer volume of opportunity and the great need that employers have, they're willing to work with folks who are doing things in a different way. Do folks have the technology and the accommodations? And Christina, you're seeing a recurring theme here around accommodations in our work that we did in Retain, Kentucky. The kinds of accommodations, we believe the most common accommodations people with long COVID are likely to need are actually schedule modifications and breaks, as Amy mentioned. A time off at certain time, naps in the middle of the day sometimes to recover and recuperate, just like Dr. Bishop and I have found in our work with people with MS and other chronic illnesses. So it's often not high ticket assistive technology or structural renovations. It's common sense kinds of solutions. The developmental stage of the customer is another one there. Is this person getting started in their career? Are we helping to find a job? The return to work hierarchy, are we going down only as far in that hierarchy as we need to, because the hierarchy is organized in we descend through the hierarchy based on complexity. So same job, same employer, that's always the easiest one to do. And it's usually the one that people want. As we work our way down, those cases become more complex, more costly, and they often cause the person to radiate out from their actual interests. So keeping it simple and honoring people's desires to go back to the kind of work that they were doing in the first place, letting them drive that process. This is just good job development and placement, but these are some of those considerations. We'll go to the next slide very quickly. Just a bit on retention and follow-up and post-employment services. In our project that we're just getting started now with Mississippi State University, we do expect to find that most people who come into this project are wanting to retain the competitive integrated employment that they already have. And those retention procedures are going to get to things like disclosure. They're going to get to things like self-advocacy and self-determination, people monitoring the way they're being treated in the workplace. And employers really do see the value in keeping good, loyal, qualified, capable workers working as long as possible. Then we have a lot to work with and a lot of leverage in that regard, but we also have to be vigilant that if employers aren't meeting our clients or customers or consumers' needs, then they know what the redress might be for that. Our friends at the Job Accommodation Network, the ADA Centers National Network. Dr. Bishop told me the other day that Job Accommodation Network has taken down a lot of its material on long COVID. We're not sure exactly why. And it's interesting because the Job Accommodation Network is working with us in this project to do a portal on employment and long COVID as part of our grant. So maybe they're moving it over onto the portal, but these things change. And I'm guessing that would be based on some sort of governmental edict, but we don't really know as far as that goes. In terms of job development, placement, and retention, we know that about a third of all adults in the United States had some involvement with the criminal justice system. And if you have a criminal record, this really does alter how we would approach your vocational rehabilitation plan. There are jobs that aren't open to people who have convictions, felony convictions on their records, for example, and all of the things that work through that. And so this isn't a long COVID specific example, but if the person has long COVID and a new chronic and unpredictable condition and also has the added disadvantage of justice system involvement, this requires us to pay a lot of attention, and it does narrow the available pool. We estimate that if you have a felony conviction, you're ruling out about 80% of the jobs in the local economy just based on that felony alone. So if people have involvement with the justice system as part of that process, as we engage with the social determinants of health, access to mental health services, and all of those other sorts of things, making sure the conditions for them to continue in their careers are right and ripe, I think that might be the other way to put it, then the outcomes are going to be better. And some of the factors that determine success or outcome in the VR process are not VR interventions at all, right? They're the circumstances in people's lives and how much can we holistically address whatever people's needs were as part of the process through referrals and what have you. I think I'm running out of breath. You're all running out of patience, and I know we have run out of time. So we are happy to hang out and take any other questions. If there's any in the chat, be glad to talk with you. We really appreciate your time and attention here this afternoon. And thanks for joining us, and enjoy the rest of the program. Thank you to my colleagues, to all of you. Thank you.